putting this together. I'm glad to have Dr. Bogulski here. She got her bachelor's in art and psychology and Spanish from University of Arkansas and Master of Science and doctorate in cognitive psychology from Penn State. She has worked at various roles as a senior data analyst in the Office of Community Health and Research, and she's currently an assistant professor in the Department of Biomedical Informatics in College of Medicine at UAMS. And her research is focused on health equity, healthcare access, and in rural and urban communities. She brings in expertise in program evaluation, community-based participatory research, and she is currently working on several projects at the Rural Telehealth Evaluation Center and the Institute of Digital Health, and the Rural Telehealth Evaluation Center is funded by her. Thank you, Cari.
Great. Can everyone see my screen? You can see the correct view of the presentation. It's hard to tell sometimes.
Yes, looks good.
Thanks, Arya. All right. Well, thank you so much for the introduction, Hari. I'm going to be presenting on some findings from one of the projects that has been funded by the as part of the Rural Telehealth Evaluation Center, of which Hari is the director of the Rural Telehealth Evaluation Center. This particular project I'm going to be presenting on today was a year 2 project, and we are funded to conduct 5 one-year projects every year. So this is we're in the middle of year 3, gearing up for year 4, and year 2 was a little bit delayed because of the process of getting Medicare data. So we have preliminary results. We are working on the write-up of some of these results for peer-reviewed manuscripts right now. So these are cutting edge right off the presses. So just a little bit about our group. Our director, our fearless leader is Hari Swaran. He is well known to this group as the director of the South Central Telehealth Resource Center. And our deputy director is Cori Hayes, who is not only an assistant professor of biomedical informatics and psychiatry, pharmacy, and practice, but also a research health scientist at the VA. Our team for this particular project that I'm presenting on today consists of myself and George Pro. We are co-leads for this project, and Dr. Mahip Acharya and Dr. Mir Ali were also key staff on this, and Claire Brown has been advising in particular on the telehealth spending portion of this particular project, and Kashina Winston is our research project manager, without whom everything would fall apart and nothing would ever get done. So I'm really grateful to everyone who made this project possible. And just a little bit, funding and disclosure that the study was supported by this particular grant mechanism from HRSA for the Rural Telehealth Research Center program, but the views that we're presenting in this do not represent the views of HRSA or the Department of Health and Human Services. And also during the course of this project, Dr. Cori Hayes was funded by a separate grant through the VA that you can read the specifics of here, and Dr. Claire Brown was also supported by the National Institute on Minority Health and Health Disparities at NIH. So just a bit of an overview of what I'm going to be talking about today. We're going to go through the background and aims of this particular project, as well as then leading into the methodology. Then I'm going to be presenting the preliminary results for AIM 1, some of our key findings from that AIM, then the preliminary results from AIM 2, and then some key findings from AIM 2. And just to kind of orient you to the way that this is structured, AIM 1 is about telehealth utilizers versus non-utilizers, so Medicare beneficiaries who utilize telehealth versus those that did not. And AIM 2 is about telehealth spending. So a little bit of background, which is going to be old hat for everyone who's on this call, I'm sure, is that telehealth, of course, has the potential to address a lot of health disparities that currently exist for underserved populations, such as those experienced by rural residents, racial ethnic minorities, and those with chronic conditions. It has the potential to reach people who have a hard time accessing healthcare services that they desperately need. As we all know, the first few months of the COVID-19 public health emergency saw unprecedented telehealth expansion. And although the rates of telehealth utilization have dropped since then, rates remain much higher than in the pre-COVID era. Although this does vary quite a bit by specialty as well. And this project in particular, which we were just called the Health Equity Project, which is overstating a bit everything that is involved in health equity. But this project in particular sought to examine how telehealth expanded for these underserved populations. And to do that, we used a 20% random sample of national Medicare claims. So this is at a national level, Medicare beneficiaries, a 20% random sample, all of their claims. So the specific aims of this project, number one, we wanted to assess trends in telehealth utilization among this national sample of Medicare beneficiaries, including comparisons between rural and urban residents, racial and ethnic minorities, and those with chronic conditions. And the second aim was to compare monthly telehealth spending, or the allowed amounts, for those who are familiar with how Medicare Medicare data are structured, among Medicare beneficiaries overall and among telehealth utilizers specifically, prior to and following the COVID-19 public health emergency, or at least the first part, including comparisons between rural and urban residents, racial ethnic minorities, and those with chronic conditions. So those were kind of the three groups of comparisons that we did for both the first and the second aim. So for our methodology, we conducted this longitudinal study using this data set from a 20% random sample of beneficiaries. We have data from 2018, 2019, and 2020. Our data for these analyses were restricted to Medicare beneficiaries who were not enrolled in a Medicare Advantage plan in any month of any year of data. And they had to be enrolled in both parts A and B, or enrolled in both part A and B through a state buy-in program to be included for analysis here. And the reasoning behind that is that we wanted to sort of have their whole universe of claims, like kind of know everything that was going on with their healthcare. And for coding, race and ethnicity was operationalized as using the Research Triangle Institute variable in the Medicare master beneficiary file, which is a method that has been used to try to make up for some incomplete data that has been demonstrated to pretty well reflect race and ethnicity for beneficiaries. And rural and urban residents was coded merging the beneficiary's zip code in a given year in the master beneficiary file with rural urban commuting area codes. And primary codes 1 to 3 were coded as urban, and primary codes 4 to 10 were coded as rural. For chronic conditions, we assessed 30 chronic conditions coded using the chronic conditions data warehouse algorithms. Each condition has a different set of criteria, and we went through each of those separately. Depending on the condition, there's a 1 or 2 year look back period. So they have specific kind of procedure codes or diagnosis codes that you want to look at to see if they had this diagnosis code. That means that's indicative that they had this chronic condition. But for some conditions, you have to look for the past 2 years to figure out if the person had that condition in the year you're looking at. So this algorithm, depending on the specific condition, uses a combination of inpatient claims, skilled nursing facility claims, home health agency claims, hospital outpatient claims, and carrier claims. So utilizing this whole universe of different kinds of services. Because even though we have 3 years of data, we can only assess chronic conditions in 2 of the years, because we need a 2-year look back period for most of the conditions require a 2-year look back period. So we only have chronic conditions assessed in 2019 and 2020. Telehealth utilization is assessed using carrier claims and including any carrier or fee-for-service claim that had a place of service of O2, a modifier of GT, GQ 95 or G0, or a CPT code of one of those 3 that's on the screen. So that's how we were operationalizing what telehealth utilization was, and anyone who had met any of those criteria in any given year was coded as a telehealth utilizer. So returning to the aims, we're first going to look at overall this analysis of beneficiaries. So looking at trends in telehealth utilization among this national sample and looking at these comparisons. So you were coded as a telehealth utilizer if you had at least one instance of telehealth utilization in a given year. So this is a very busy table, and I come from psychology where we don't have tables this big, and I've very quickly gotten very comfortable having giant tables that are hard to look at, but I'm going to kind of walk through it and sort of highlight some of the findings here. So the first thing I want to point out here is that every column is, or every percentage that's in parentheses is a column percentage. So like right up here in 2018, 55.6% of all telehealth utilizers were rural and 44.4% were urban. So this is a percentage at the column level. So just looking across the years and the comparisons, what you can see is that the percentage of all telehealth utilizers who live in rural areas goes down, and it goes down quite a bit in 2020 relative to 2019. And this is perhaps very unsurprising for those on this call, given what we know about the telehealth waivers for CMS, or the Centers for Medicaid and Medicare Services, the waivers that were issued for their reimbursement, specifically in this case, that urban residents were able to, there were a lot fewer restrictions for urban residents to receive telehealth services prior to 2020 when these waivers were issued. If you were an urban beneficiary to receive telehealth that would be paid for by Medicare, you needed to have a specific chronic condition. And so it's perhaps unsurprising that when that restriction was waived, then urban utilization skyrocketed up to 82% of all telehealth utilizers in 2020 were urban, as opposed to the 44 and 49% in 2018 and 2019. And then looking at race and ethnicity, non-Hispanic white beneficiaries were, unsurprisingly, especially among a Medicare population, the vast majority of telehealth utilizers, but this percentage even increased quite a little bit from 2019 to 2020. So the percentage of all telehealth utilizers was around 79% in 2018 and 2019, and a little bit closer to 80% in 2020. And I also just want to highlight, unsurprising again to everyone on this call, every subgroup saw increased telehealth utilization in 2020. That is not a shocking finding. No one is surprised by this. This is not groundbreaking. But what we're specifically interested in this project is that did that expansion happen equitably for all of these subgroups? So in addition to the increase in the percentage of all utilizers identifying as non-Hispanic white, there was also an increase in non-Hispanic Asian or Pacific Islanders, 1.5, 1.8, and then 2.8% of all telehealth utilizers in 2020. On the flip side, non-Hispanic, Black, and African American Medicare beneficiaries had a slight decrease in the overall percentage from 9.6% in 2019 to 8.4% in 2020. Hispanic and non-Hispanic American Indian and Alaskan Native beneficiaries also saw decreases in the overall percentage of telehealth utilizers. And finally, looking at the presence of chronic conditions, and just as a reminder, we assessed 30 chronic conditions, and I grouped beneficiaries into 5 categories, either having 0 chronic conditions, 1 chronic condition, 2 chronic conditions, 3 chronic conditions, or 4 or more chronic conditions. And what you can see is that the percentage of telehealth utilizers who had 0 chronic conditions went down slightly in 2020, 5.4% relative to 5.8%. And the percentage of beneficiaries who had 4 or more chronic conditions went down actually quite a bit. So 62.5% in 2019 to 54.1% in 2020. But those with 1, 2, or 3 chronic conditions, that percentage went up slightly from 10.1 to 11.1 for 1 chronic condition, 10.6 to 14.3 for 2, and up from 11% to 15% for 3 chronic conditions. There was that increase. And then this is looking at the 30 chronic conditions specifically. This is also, again, quite busy, but what you can see here is on the y-axis, we have the percentage of telehealth utilizers and non-utilizers who meet the criteria for each of these 30 conditions. And then in the yellow bars, which is on the left for anyone who's experiencing color blindness, the leftmost bar that is yellow is non-utilizers, and green on the right is for utilizers. So you can see that telehealth utilizers in a lot of the bars, not all of them, not for all conditions, but that telehealth utilizers make up a larger proportion than non-utilizers that meet the criteria for those conditions. So of all telehealth utilizers, do they meet the criteria for diabetes versus of all telehealth non-utilizers, do they meet the criteria for, say, diabetes? So some of the sort of key takeaways I wanted to highlight from looking at this from AIM-1, and again, just I think I said this at the top, but we are currently working on doing a logistic regression model right now to kind of tease out maybe some of these interactions between, you know, rural, urban, race, ethnicity, looking at some of those things. So this is just kind of a descriptive preliminary look at our data. But among the Medicare beneficiaries, and telehealth utilization surged in 2020 relative to 2018 and 2019. This is an unsurprising finding. Anyone probably could have predicted this given what we all know happened. But urban telehealth surged a lot more than rural telehealth. The rural increase was over 2,000%, but the urban increase was over 11,000%. So it did expand quite a bit more for urban beneficiaries. But again, that's not super surprising given what we know happened at the policy level for telehealth reimbursement for Medicare. Also for non-Hispanic, Black, and African American, American Indian, Alaska Native, and Hispanic beneficiaries were a smaller proportion of all telehealth utilizers in 2020 relative to 2019. So even though telehealth expanded among all of these groups, there were more telehealth beneficiaries utilizing telehealth among Black, American Indian, Alaska Native, and Hispanic beneficiaries. The relative percentage of all telehealth utilizers who were Black, American Indian, Alaska Native, and Hispanic was smaller in 2020 relative to 2019. So expansion was largest for non-Hispanic white beneficiaries and non-Hispanic Asian and Pacific Islander. In addition, Medicare beneficiaries with 1, 2, or 3 chronic conditions were a larger proportion of all telehealth utilizers in 2020 than in 2019. But those with 0 chronic conditions, or those who have the fewest or no chronic conditions, and those with 4 or more chronic conditions, those who have the most health concerns, were a smaller proportion of telehealth utilizers in 2020 relative to 2019. So those who are the sickest and the least sick had those smaller proportions in 2020. And of the 30 chronic conditions, and I had that big sort of chart, the graph of graphs that I had of all the conditions, only 9 of the 30 chronic conditions investigated showed a larger proportion of all telehealth utilizers in 2020 than in 2019. So for example, hypertension, 68.5% of all telehealth utilizers had hypertension in 2019, and 68.7% of all telehealth utilizers in 2020 had hypertension. And it's worth noting that hypertension and hyperlipidemia are the 2 most common chronic conditions in the entire data set among everybody. So it is noteworthy, I think, that of those that actually had an increase in overall percentage, you can see that it is some of the big chronic conditions. And these are the rest of the chronic conditions that had slight increases among telehealth utilizers. Okay, so we're moving on to address AIM-2, which is looking at telehealth spending among Medicare beneficiaries. So we're looking at monthly telehealth spending. So in the last AIM, we were looking at results by year, so 2018 versus 2019 versus 2020. And now we are looking at spending in a month. And we are looking at this, the monthly allowed amount is the variable we're using in this analysis among Medicare beneficiaries overall, and then among these groups that we've talked about. So this is a very simple chart. This is just looking at the overall amount of money that was spent in each month on telehealth, using that same definition of what telehealth means and just adding up anything that was in a given month from January 2018 through December 2020, how much was spent on telehealth. And you can see that telehealth spending overall peaked in April and then was starting to show kind of a surge back up in December 2020. This is the latest data that we have so far. I think we are working on trying to expand out to 2021 data to see. And it's an interesting thing because you're also reaching the end of the year, but this was also coincident with when the third wave of COVID was surging. So this is just taking that blue line is just taking the last third of this, the line on the previous graph and overlaying it on top of weekly COVID-19 cases. And so you can see that the peak of telehealth spending was coincident with that first wave of COVID. And then even through the second wave, telehealth spending was declining, but then it started peaking again toward the end of 2020 when the third wave of COVID was really rising. So this looks like the same graph, but I can assure you it's not. This is per beneficiary telehealth spending. So it's taking that first graph and just looking at overall spending and dividing it by the total number of Medicare beneficiaries in that month who had coverage. So it, again, has a very similar pattern. It's just a different value on the y-axis. It's average telehealth spending per beneficiary. But this graph is per telehealth utilizer spending overall. So this is taking the overall amount of telehealth that was spent on telehealth services in each month and dividing it by the total number of beneficiaries who use telehealth at all. And they don't have to use it in that month. So just if they're a person, I think, who was utilizing telehealth at any point in that year, they were in that denominator. And so what you can see is that there was a drop in March 2020 as things were perhaps the most hectic. But then if you kind of ignore that dip, that you can see that there is kind of a slight increase in the per utilizer spending, that it continues to kind of go up over time. So what we wanted to do next was take this same chart and look at telehealth spending per telehealth utilizer and compare them between rural, urban, racial, ethnic minorities, and those with chronic conditions or different numbers of chronic conditions. So this is the rural urban comparison, with urban is in yellow on the top and rural is in green on sort of mostly on the bottom. And what you can see is that even though before March of 2020, you had urban beneficiaries were much more limited in their ability to receive telehealth services. Per telehealth utilizer, spending was higher. Although this is, again, perhaps unsurprising, given that to be an urban Medicare beneficiary receiving telehealth services, it was much more restricted to those who had end-stage renal disease, stroke, and I think a few other specific conditions permitted an urban beneficiary to receive telehealth services prior. So it makes some sense, at least in my mind, that you might have overall spending would be a little bit higher because the universe of people who could use telehealth among urban beneficiaries was, they were much more likely to have a chronic condition. But then when you look after the declaration of the COVID-19 public health emergency, urban beneficiaries are still much higher with per telehealth utilizer spending, but that gap is even larger. So again, if we go back to the results of AIM-1, there are more, the expansion among telehealth utilization was even greater for urban beneficiaries. And it's now opening up to those who are perhaps less sick potentially because of the restrictions that were lifted on who among urban beneficiaries can utilize telehealth services, but there's still per telehealth utilizer spending was greater among urban beneficiaries relative to rural. So now looking at per telehealth utilizer spending for those, we have a, yeah, okay, sorry, for chronic conditions. So, and these, I'm trying to use our tech colors, but sometimes it gets hard when you have a lot of categories, but the gray line that is all on the bottom are those beneficiaries that have 0 chronic conditions. There's a light yellow line that is one chronic condition, a light green line that is two chronic conditions, a darker yellow line that's three, and then the top line, the darker green, is four or more chronic conditions. And what you can see is, again, this drop in March 2020 in per telehealth utilizer spending for all of these groups, but that the sort of steepness of the line, if you were sort of look at, what's the average slope of this line? Is it going up? Is it going down over time? That the slope is increasing a lot more for 0, 1, 2, and 3 chronic condition beneficiaries. It's a little bit more static for 4 or more chronic conditions. Again, ignoring that dip that happens in March 2020, if you kind of imagine that that dip was gone, it almost looks like it's kind of the same slope. And again, we are currently, like I literally was running this code last night, looking at doing these models to sort of look at this from a more statistically robust kind of way. But that is what it looks like, just descriptively, is it looks like per telehealth utilizer spending had the largest increases for those with the fewest chronic conditions in the COVID-19 era versus the pre-COVID era. So some of the key findings for this second aim about telehealth spending: among Medicare beneficiaries, overall telehealth spending surged in 2020, peaking in April 2020. However, per telehealth utilizer spending has shown a continual increase following this drop in March of 2020. And that gaps in per telehealth utilizer spending have grown between urban and rural beneficiaries. And so that, again, that even though urban was higher in the pre-COVID era, that gap got even larger in the during COVID. However, the gap in per telehealth utilizer spending has decreased among those with or without chronic conditions, with those who have fewer chronic conditions seeing larger increases than those who have 4 or more chronic conditions. And that is really the end of the presentation that I have prepared. I have a lot of extra slides if people have specific questions about some other comparisons. So I would love to entertain questions.
Thank you, Cari, for the nice overview. Joe Schaffner, he's the Assistant Director for Outreach for the South Central Telehealth Resource Center. Arya, can Joe go ahead and get questions, or how do you want to do it?
Yeah, so feel free to use the Q&A function to interact, or I know, can the audience use the chat function, Arya, or is that just us?
Either one will work, the Q&A or chat.
Okay, yeah. If you have any questions for Dr. Bogulski, thank you, Cari, for that. That was a lot of interesting info. I'm curious, and you may have said this, but and I may have missed it, but after the declaration of the public health emergency, you stated that there was a larger gap in spending between urban and rural. Was there a reason identified for that? Yeah, there.
Yeah, so we are still working on sort of analyzing what this means in particular. But I think it's especially interesting because, again, the urban beneficiaries who are utilizing telehealth before COVID might have been using, they had end-stage renal disease, they had suffered a stroke. It's a lot of people who had a lot of health concerns that could have had a lot, been very expensive to manage. So, and then it got opened up to anybody in an urban area who could use these telehealth services. And so we're still kind of working on what exactly that means, but it could be the case that the way that telehealth was being utilized, even among those with chronic conditions before COVID, it was not necessary. Because one big limitation with these kinds of data is you don't know what telehealth is substitutive versus supplemental, right? You don't know what if it's taking the place of an in-person visit, or if it's in addition, like an additional check-in or something. So that is something that I'm really interested in digging into more in the future, is looking at what kinds of visits are happening. It is the pre-March 2020 spending is that mostly happening for supplemental visits. So the only maybe urban beneficiaries who were using telehealth services were those who were doing some stuff in addition to their in-person things. So they weren't doing like the bulk of their care via telehealth services, but during COVID that shifted where they had a lot more of this substitutive kind of like something that would have been done in person suddenly became something that they were doing over telehealth. So I to answer your question, I don't know. And we're still kind of working on some other explanations that could address that very question, because I think it is really interesting, especially because you had urban beneficiaries who didn't have chronic conditions in that group and the spending is higher. So
Yeah, and everything you mentioned was just as interesting. So yeah, like you said, it'd be interesting to know. Looks like you started to answer one of the questions we had here. I'm gonna go ahead and read it for the audience. Have you gathered any data for the 2020-2023 period? How does it compare to this data you've presented?
yeah, so I was just typing a response, but we are working on getting the data from 2021 because I think it will be really interesting to look at once we, because I think we all kind of know that the way that people were utilizing healthcare and the way they were living their lives in 2021 was really different than in 2020, especially because the vaccine rollout was really happening at the end of 2020. A lot of behaviors were changing, local policies were changing. So I'm really interested in that, but unfortunately we don't have those data yet. And the process of so we acquired this, 20% random sample of the actual claims, and we didn't do I think they're called RIF. There's like two different types of Medicaid. They just take a long time to acquire, and there is a bit of a delay. So we haven't gotten those yet, but we're so interested in digging in further. That's a great question.
Well, and I know a lot of broadband infrastructure money came in during that time too, so that's probably going to change a lot of things too. Another question here, is it possible to somehow analyze your data looking at education level or income level and telehealth use?
Yeah, I am not aware of like a high quality variables that exist in those Medicare data. Now, what we could do is look at sort of the median income level, or look at some of those at the county level or zip code level. So we could kind of look at the demographics of a particular area, but I'm not aware of sort of high quality data that are in the beneficiary file to look at those kinds of things. So that's a great question that I wish that we had the data to kind of speak to more, but I think unfortunately that's not part of the data set that we have. But we could look at it kind of in that particular area that this person comes from. What is the average education level? What's the median income? But it's a really good question.
Yeah. I'm not seeing any other questions here. Hari, do you have anything on your end?
No, I think this is pretty valuable information. I think it'll help shaping things going, or at least provide some information. Yeah, I think thank you, Cari, for taking your time to present this.
Yeah, thank you.
Thank you. I'm just going to bring up our closing slides here. Just a reminder that our next webinar will be held on Thursday, July 20th, and that will be hosted by the Pacific Basin Telehealth Resource Center. Please check the consortium website, telehealthresourcecenter.org, for more information. And lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar. Your feedback is very valuable to us. Thank you again to Cari for her presentation today, and to the South Central Telehealth Resource Center for hosting today's webinar. Have a great day, everyone.